I feel like once a population where everybody has had the opportunity to get vaccinated, then, I feel like it's on those people who've made the choice not to.
Welcome to the RANE Insights on COVID-19 podcast. I'm Emily Donahue. Let's listen as RANE founder David Lawrence speaks with Drs. Fred Southwick and Bill Lang for our weekly coronavirus update.
Fred, Bill, again, thanks so much in advance for spending some time with us. I know one thing that is very much on the top of your mind now that we're going to the Greek alphabet is the Delta variant, which people might more readily recognize as the Indian strain or Indian deviant. What can you share with us?
Well, I guess I can start on this one, Bill. But this is a unique variant. It's called the B1.617.2, and it has 12 mutations in the spike protein. But the ones that seem to be of the most interest are a tyrosine for a lysine at amino acid 478. And that one appears to confer even higher affinity for the ACE2 receptor than the UK mutant did. As a consequence of this, and the other mutation is the P681R, which is a proline for an arginine, and that's in the furin cleavage site. Now, why is the furin cleavage site important? It turns out that the furin is an enzyme in host cells, and it acts to cleave the spike protein, and when it's cut at this spot, it allows the virus to internalize more readily. So both of these mutations appear to cause this particular virus to be 40 to 60% more infectious than the UK variant was. So that's why if you look and we know in Great Britain and particularly London, they've now been studying this, and it indeed is 40 to 60% more infectious than the UK variant. And there's a concern that it's also more virulent. That is, it causes more severe disease. And that makes sense. If more virus can get into cells more quickly, it would tend to overwhelm the host and make it more severe. The other concern which they're seeing in India, and I can speak from personal experience, I'm working with a number of Indian physicians, is if it gets into a household, virtually everyone, over 90%, become infected very, very quickly. So now the household contact rate is very, very high. In the U.S., it was about 50 to 55%. Now it's more like 90 to 95% of households. If one person comes into the household with this variant, everybody gets it, basically. So I think these are all great concerns. And one of the problems is, you remember, the UK variant, CDC has been talking about double masking. Well, this, it looks like only an N95 or a very effective, almost respirator type of mask will be protective for this particular variant. So the one good news is if you've had both doses of the Pfizer or the Moderna, you are protected 83, 85% efficacy. A single dose, you're only about 35% protected. So, Bill, your thoughts?
Yeah, and of earlier this week, it looks like the J&J also is, it's not as protective as the mRNA vaccines, but it also appears that J&J is effective against the Delta variant. One of the good pieces of news is that the case rate in India is down to only about 20% of where it was just 6 weeks ago. So I don't know if they certainly it's not because of their immunization program. They do have a very effective immunization program in India, but this appears that while some of it may be that it's pushed out to the countryside where you don't count as effectively, at least in the big cities, it appears that. Is this a herd immunity effect, or because it was so virulent and is spread so rapidly throughout the population? But the rate is down dramatically from 6 weeks ago.
Yeah, actually, Bill, with regard to the countryside, the clinic that I'm working with is in the countryside. And they, yes, the last 2 or 3 days, they've had more admissions. So I think one of the problems is they may not be counting those in the countryside right now.
Right, and that's been an issue all along, and that's so even a few weeks ago, I think we talked about that's the concern. Is it running up on the countryside? But in the big cities, it's definitely going down dramatically, and that probably is herd immunity effect because it's not vaccine effect.
Yeah, I would agree. This is so efficient at spreading that virtually everyone is getting it in the cities where you're in close contact, and that does make sense.
But the other I think evidence that there's a problem with this is in the UK. As we know, in the UK, over the past 2 months, up until about 10 days ago, the rate was 3 cases per 100,000 per day, and it was locked in there for almost 2 months. Beginning about 10 days ago, the rate started going up, and the rate today was 11 cases per 100,000 per day in the UK. So it's almost 4 times what it was just 10 days ago, and that's corresponded to the Delta variant becoming the predominant variant in the UK. We haven't seen it become the predominant variant in the US yet, but I think that with international travel and given what we seem to know now about its infectivity, I think it's probably just a matter of time until it gets over here, unless, as Scott Gottlieb said, we can beat it to the punch with getting more and more widespread vaccination.
I agree. This puts even more pressure and need to encourage vaccination. So any way we can do that is going to be critical.
But that's a problem right now because we have vaccination rates that have essentially stalled. The kids are getting vaccinated, but it's not pushing the rates up. We're still sitting. We peaked out in March at roughly 4 million vaccinations per day. I guess about late March, early April, 4 million vaccinations per day. Last week, it was just over 1 million vaccinations per day, and that's despite opening vaccinations to 12 years and up. There's a significant issue with convincing people that they need to get vaccinated.
I know, Bill, it's very discouraging, very discouraging.
So, Bill and Fred, let me just unpack that because I know you have insights in terms of who is coming down with the virus now and whether they've been vaccinated. What is the data actually showing in terms of who's coming down with the virus and the vaccination rates, and are the people falling within particular age groups geographically? What do you know?
Well, what we are seeing, I haven't gone into the age demographics of the new cases. That data is available. I can look at it, and I'll have that for next week. But what we are seeing is that hospitalizations have not been up. The last couple of days, hospitalization rates have been up, but it appears that may be an anomaly due to some anomalous reporting from certain states, which we'll talk about that in a minute because that's a problem. But the death rate, which it's a little bit harder to have problems with the death rates, that continues to go down. So what that's telling us is that the cases are happening in a less at-risk population. These people are still getting sick, people are still getting hospitalized, but CDC, for example, has shown that while the case rates among adolescents, specifically talking about 12 to 16-year-olds, has gone up, it has, and in fact, the 12 to 16-year-old case rate has been higher than the 5 to 11-year-old case rate, which was not the case earlier on in the pandemic. But while the case rate has gone up, there haven't been any deaths associated with it, even amongst at-risk population.
Bill, we've been discussing the fact that various states, various communities are no longer reporting data as assiduously and on as a timely basis as they had been. And I'd be curious what you're seeing out there, at least here in the United States, and what are the implications if, in fact, real-time data is not coming forward.
Well, and that's just it. We're seeing data still at a weekly level, so it should still be reasonable to do roll-ups of data on a week-to-week basis, and not on a daily basis anymore, at least at a national level, because it will not be comparable to previous weeks. But there's also a case to be made that are we tracking the same thing today that we tracked just 3 months ago? We're looking at cases. But 3 months ago, when you had a case, it was fairly evenly distributed or we knew what the distribution was amongst the population. And because the immunization rate, even amongst the at-risk people, was not high enough to have that significant an effect. Today, we're almost all, I'm talking 85-90% of the at-risk population are in fact vaccinated. So what we're seeing case rates now, we're not seeing case rates amongst a population that has lots of at-risk people. In fact, what we're seeing is case rates amongst a population that is not at risk for severe disease and death. Now, in the United States, we're looking at primarily the UK variant, not yet the Delta variant. That may change the calculus on that. But for now, you can't do the direct one-to-one comparison between case rates of June and case rates that we talked about in January, February.
Yeah, I would agree with Bill on that. And what's happened is those 65 and older, the percentage of vaccinated in many parts of the country is 85% have at least gotten one, and it's somewhere around 75% have gotten 2 shots. So the elderly, which are the group that were more likely to be hospitalized and to die, are now protected. So we're looking at the people that are more susceptible are less likely to get severe disease and less likely to die from the infection.
Right, we've gone from hospitalization rates as high as 40 per 100,000 in the United States, averaged overall in the January timeframe. Now we're looking at 6 hospitalizations per 100,000. I mean, that is down to levels that are more comparable with flu season, not with what we saw early on in this COVID epidemic. Speaking of that, one of the big considerations is going to be, when does this become much more comparable in terms of disease rates and hospitalizations and death rate to flu? And what we know is for immunized people, those rates are all much lower than they are even for immunized flu. It's still high, it's still much higher for those who are not immunized. So again, this becomes critical that we get people immunized. And it's unfortunately, there's just so many people out there that are resistant to immunization.
Yeah, I agree with Bill. It's remember, this virus has a reproductive rate of 2 to 2.5 for the wild type, and probably 3 to 3.5 for the UK variant, and possibly 5 for the Delta variant. Now, influenza is I think, Bill, about 1.2, so it's much less infectious. So, and the efficacy of the vaccine for influenza is it's varied between 50 and 70%. The efficacy for these viruses for this virus for serious disease, hospitalization, and death is 100%. So the difference between vaccinated and unvaccinated is very large, and the risk-benefit ratio is the risk is very low and the benefit is very, very high. And anybody that goes over the true facts should want to get the vaccine.
Fred, I'll let you take shots at me on this, but I'm a little bit callous on this one. I feel like once a population, which is not universal at all, once a population we're at the point where everybody has had the opportunity to get vaccinated, then, I feel like it's on those people who have made the choice not to. Yes, there's a small number who, for medical reasons, can't. That's a very small number. So I feel like we still want to keep the number down, because people still can get infected and spread it, even if vaccinated. But that's a very, very low rate. Do we really need to have significant restrictions on economy and society and activities that people want to do amongst those who are vaccinated, because we're still protecting those who have made a choice not to get vaccinated?
Well, the one issue, Bill, is the generation of new variants, or the spread of more virulent and more aggressive variants. And that's where the fact that a certain percent are not vaccinated could become a problem. And if we get a variant that escapes from vaccines, in other words, vaccines do not protect against it, then we're all in trouble. So the problem with the group that's resisting vaccine is they have the potential to endanger all of society.
So let me simplify the message. If everything you're seeing in the data, if you have been vaccinated, you're safe. And if the virus jumps and, for some reason you do contract it, all the data says it's not resulting in death, hospitalization, or serious illness. And somewhat ironically, the people who are not taking the vaccine are in fact more at risk to themselves, and to other people who have not been vaccinated. And with the one caveat around that, Fred, is the one you are stating, which is if many people are not being vaccinated, the risk of the variant or variants jumping, morphing, and becoming a bigger problem increase. So yet a reason to continue to keep the pressure on to have more and more people vaccinated. Would that be a fair summary?
Yeah, yes, David, that's an excellent summary. And one of the areas, just to go a little beyond this, one of the major issues that we're encountering, and I know you're advising on, is the problem of the workplace. And are you going to have two populations, one that's wearing masks and one that's not? And what does that mean as far as a cohesiveness of the workforce? And what does it mean about whether or not someone's going to be truthful with regards to whether or not they're vaccinated? And if they're not truthful, then they are risk themselves and others that are unvaccinated. So it's really a real conundrum, and really has the potential to create a sense of antagonism among members of a workforce.
And Bill, I know you're dealing with some of these issues as well. Advice for employers.
So this is the one where the recommendation that I've been making, and as in a number of cases the HR lawyers have supported, is to say that you must wear a mask and social distance in the workplace, period. However, if you are vaccinated, then you do not have to wear a mask or social distance. Now, that gets back to my philosophy of the people who are not vaccinated, with the very small exception of those people who have a medical or religious contraindication to getting vaccinated. They're putting themselves at risk, not to a great extent putting everybody else at risk, except for the caveat of the potential to help increase the risk of a new variant. That does mean that the people who do have a medical contraindication, which is well less than 1% of the population, and those that have a deeply held religious objection to getting vaccination or getting this particular vaccination, they need to be accommodated. And that is a typical ADA, Americans with Disability Act accommodations that need to be made, but workplaces know how to do that. But otherwise, I've been advocating letting people who are vaccinated take their masks off.
Bill, I completely agree with that, and what you said. I think in the workplace, this makes perfect sense, and that those that are vaccinated shouldn't have to wear a mask, and those that aren't vaccinated should, if they want to protect themselves. If they want to endanger themselves, that's their choice.
And my hope is that will further increase the rate of vaccination. I think especially as we still have an authorized but not fully approved vaccine, everybody feels that they're in a very difficult position to mandate vaccination, even though the U.S. EEOC has said that you can do it, and most lawyers are saying that you can do it. I think people feel very uncomfortable with mandating an authorized vaccine. Now, over the course of the next couple of months, what we're hearing is that at least for adults, that both of the mRNA vaccines will likely be approved. Once that happens, then there may be some more pressure, especially on things like school. Do we include this as a mandatory school vaccination for high school aged kids? We are hearing that many, I don't know if I could say most, but many colleges are mandating vaccination for the students, although interestingly they are not mandating vaccination in many cases for the faculty, and some of that gets into the OSHA, to the workers' compensation liability issues, because if you do mandate a vaccine and someone has a problem with the vaccine, then the organization mandating it has bought that expense for however long that may be.
All right, there's a lot to unpack, and we'll probably save this for the next session. But apropos, I felt it's somewhat ironic. OSHA, I think, is just starting to provide, more than a year later, some guidelines for the office space, or is thinking about it. Number one. Number two, I sort of dove into some of the reasons why people are not being vaccinated, at least the online reasons. And although I had heard about it, I was a little bit taken aback by what appear to be a large number of followers who believe that the vaccine is part of a government conspiracy to inject microchips inside of people that in turn will track them. I also note there are a number of professional athletes who have not been vaccinated out of concern that this will interfere or impede with their professional performance. And I would, further note that even in some of the world's leading professional organizations, there are otherwise highly intelligent people who have just said, I'm not doing it. I don't trust the data yet. I don't trust the amount of testing and protocols. And in essence, they're also just saying that they have a abiding distrust with government approval process, and having seen too many times where things have been approved for the marketplace only to be recalled or rescinded, or conflicts of interest to have been exposed. So obviously that's a complexity of matters, and the issue of mandatory or non-mandatory, which Bill and Fred, I'll mention I'm going to a baseball game tonight, and you've told me it's safe to do so because I've been fully vaccinated a number of months now. I will bring a mask. I'll keep it on probably the entire time unless I'm eating or drinking. But interesting to get into the ballpark. I have to show proof of vaccination, either the certificate or a photograph on my phone, or proof of having been tested within the last 72 hours. And I haven't heard, it's interesting because I haven't heard a great deal of protests from baseball fans of this particular team or going out to see the team about those requirements. But that may beg a bigger issue in terms of whether there are a lot of counterfeit documents floating around and people feel they can get in by forging a photograph on their phone or whatever. But I throw that to you for consideration next week, unless you have some quick comments, and then I just have a closing question.
Again, my only quick comment would be that if someone is forging their vaccine certificate in order to not protect themselves, the primary person that they're putting at risk is themselves. But the secondary people they're putting at risk is others who have made a choice to take the risk and not get vaccinated. They are not putting at risk to any significant level those people who are taking the prudent course and getting vaccinated.
All right, just in conclusion, people continue to wonder about making summer plans. A lot of families have been separated. People want to whether drive or fly. They're talking about opening up Europe now and things like that. Any advice just in terms of making plans, often with non-refundable airline tickets?
Well, I can speak for my own family. I have a number of grandchildren and children that we want to get together, and I've said we don't get together if everybody's not vaccinated. That can be. Now, there's obviously the very young children will not be vaccinated, but everyone else should be and will be before we get together. And I think that eliminates a lot of the logistic problems that some families may have. And remember, prior to the vaccine, there were a number of family reunions where several members died as a consequence of such family reunions. So the issue of vaccine, I think, is truly a life or death issue among families.
And in addition to that, normally I'm fairly open-minded about doing things. I probably haven't been as strictly restricting things as much as others have been, but I'm a little uncomfortable with international travel right now as long as we can still keep pushing our vaccination rate, because since the Delta variant has not gotten a good foothold in the United States yet, the way that we can keep that from happening is by keeping down the amount of travel. It's not going to be, we do have travel, so it is going to get here, and once it gets here, it is going to be likely to take off and become predominant unless we've gotten so far ahead with the vaccinations. So if we can do like New York is doing, we're going for 70% of the adults. That'll have a major impact, but we've got to get places vaccinated. And I would really want to do that before we wide open to travel internationally.
I completely agree with Bill on this.
Okay. Well, guys, thank you again for a very informative session. Look forward to following up next week, and particularly appreciation for your attention to the data and the various trends and helping us keep ahead of important insights. So thank you again. Just have a great weekend. Stay safe.
Thank you, David.
Thanks, David.
Dr. Bill Lang is an expert in public health responses to biological incidents, including pandemics. Dr. Fred Southwick is an infectious disease specialist at the University of Florida College of Medicine. Both doctors are part of the RANE Expert Network. Individuals and organizations turn to RANE for risk intelligence that cuts through the hype to focus on what they need to know, what to expect, and what to do. Sign up for our coronavirus solution and get critical information on the COVID-19 pandemic delivered daily. Visit us at ranenetwork.com. That's RANE network.com. I'm Emily Donahue. Thanks for listening.